Hello. Thank you for tuning in today. I'm very pleased to have a program to talk about some advances in treatment-resistant depression with just a wonderful group of experts. As a reminder, I'm Dr. Steve Strakowski. I'm a professor of psychiatry at the Indiana University School of Medicine and also at the University of Texas at Austin. Welcome to the three of you. I would like to introduce each of you. So Dr. Nolan Williams is a recently promoted, congratulations, Associate Professor of Psychiatry at Stanford and the Director of the Stanford Brain Stimulation Lab. Dr. Linda Carpenter, who is a Professor of Psychiatry at Brown and the Director of the Butler Hospital Clinic and the Neuromodulation Research Facility. And then finally, Dr. Scott Aronson is Chief Science Officer at the Institute for Advanced Diagnostics and Therapeutics at Sheppard Pratt and a Professor of Psychiatry at Maryland. So welcome, everyone. So to start out, Nolan, I know it's been about a year ago now that in the American Journal you published really your landmark finding of a new approach with transmagnetic stimulation to treat treatment-resistant depression. Could you tell us a little about this? I know it's called SAINT, but tell us what you all did, what you learned.
Yeah, absolutely. So if you think about kind of the old way of thinking about TMS is that it was kind of one protocol baked into one device, and then that protocol plus the device is the treatment, and the treatment is kind of fixed, if you will. Thinking about it a different way and thinking about the TMS device as kind of a conduit for a whole host of treatments, right? And folks on this call have been pioneers in getting other indications explored and that sort of thing as far as stimulating other brain regions outside of the dorsolateral prefrontal cortex and trying to treat obsessive compulsive disorder or PTSD or whatever it may be. In this case, we thought about it and we said, okay, we would like to take what has been done, kind of pioneered as far as depression treatment, and really try to speed it up, make it a treatment for high acuity psychiatric emergencies. The current approved TMS treatment, the kind of conventional rTMS for depression, really doesn't work in the sort of time frame that you need for a psychiatric emergency. And so we thought a lot about this. If you look, the average length of stay, for an inpatient with suicidal depression, around 7 to 10 days, and so, a 4 to 6 week course wasn't going to really work. And so we went in and kind of re-engineered TMS in the domains of where, how, and how much, right? Kind of a reorganization in space, time, and dose is another way of thinking about it, right? And the idea there was, it was a new form of stimulation called theta burst stimulation, which makes TMS much more efficient. It's kind of like in this way of thinking about the TMS device as a conduit for various treatments. It's almost like a new drug, if you will, right? It's a new kind of stimulation approach that was much more efficient. And so instead of just giving that once a day, we figured out a way to take the entire FDA approved theta burst course and compress it from 6 weeks into a single day. So the 18,000 pulses that were approved by the FDA over 6 weeks, we figured out a way to compress that into a single day and use a certain type of MRI to optimize at an individual level the best spot within the dorsolateral prefrontal cortex to be able to deliver that treatment course. And we didn't just decide to give it for a day, but we went back to the drawing board based off of, and really thankful that Linda's here, based off of some of Linda and Mark George's work, where they found that continuing to treat over an extended period of time with conventional TMS, essentially going up on the dose over months in that case, led to better improvements in depressive symptoms. And in this case, we said, okay, if we're giving an entire course in a day, in an optimized spot in the brain, maybe we can do that over multiple days, the equivalent of, in this case, 7.5 months worth of TMS over 5 days, and give kind of a very potent kind of full dose of TMS and treat a larger range of individuals. And over three separate studies, we were able to observe even people that had failed electroconvulsive therapy in our first study we were able to see dramatic and rapid improvements in treatment. And in that last study that you mentioned, the 2022 Cole paper, we were able to observe those rapid dramatic shifts in mood were only in the active group and not in the sham group, with the blind completely intact, right? Which is really nice. And it's really, you know, kind of emulating the same sort of thinking that the ketamine pioneers have had for 20 years, right? That depression can be treated not over the course of months, but over the course of days, right? We can get people well in a short period of time if we do it in a personalized way, and we do it in a way that's aligned with brain physiology and with the amount of dose that everyone needs.
And several of those are advances over our traditional approach to psychiatric research, right? And so I appreciate that. It seems like a little thing, but I know you asked people if they knew they were getting placebo or not, and they were not able to tell. And I don't think we do that enough. Linda, he alluded to your prior work as kind of setting him up. We all stand on the shoulders of giants. I guess he got to talk with you actually being here. So how does some of your prior work contribute this, and how do you think about what they've done with Saint that's innovative or novel?
Well, we've learned a lot about TMS, but up until this really recent development, we haven't been able to get more than about 50% of people better. And that's what's making this particular treatment approach really noteworthy, is regardless of how we've done it. I mean, we can get more people better if we, as Nolan said, if you give more treatments, you keep going beyond 4 or 6 weeks. But by and large, across all naturalistic studies, you see about 50% of people respond and about 1/3 of people remit. So we've all been looking for and thinking about ways that we could make those numbers even better. And Nolan's work really combined a couple, as he mentioned, a couple of different elements, and taking some time to tease those apart is something that the field's going to continue to work on. Not only do you get this huge dose each day for 5 days, but you also get a different type of targeting, and it's not only that, you've got the dose and you've got the theta burst and a kind of a unique theta burst protocol for each of the treatments that you have 10 times a day. So there are a lot of elements to the secret sauce, if you will, and all those things come together to make a really promising outcome, and at least what now is a relatively small sample size, but a compelling and rigorous design for a clinical trial.
Great, that's right, and that's a good point. It's still being developed, right? And we still had a relatively small group of people with it, so there's still lots to learn. And with that in mind, Scott, I mean, I hear we dosed higher, we use theta bursts instead of other approaches, and we localized. Do we know yet which, or if all three are necessary to gain improvement over traditional approaches?
Steve, if I can take a step back and just sort of give a little bit of color commentary about just how revolutionary what Nolan and his group has done. Because, and I absolutely agree with Linda, all of us deal with this 50% response rate, 33% remission rate, but that's in folks with moderate to marked depression. And Nolan is looking at the worst of the worst. He's really looking at the folks who are generally hospitalized with severe suicidal ideation. These are folks that are excluded from almost any other TMS study that's been done. So he's getting pretty extraordinary results with an even sicker population. The other thing that I think is really important to underscore is, I go to these scientific meetings multiple times a year, and I walk around and see everybody's pretty MRI pictures on all these posters. And rarely do you see MRI results actually changing outcomes for patients. This is actually one of the first clinical trials in which you're using targeted TMS based on a particular MRI profile that appears to be improving outcomes. So this is finally we're getting to the point that our understanding of neuroanatomy and neurophysiology may in fact be improving outcomes for some incredibly sick folks.
So Go ahead.
So I think we're early in this paradigm as to who this is applicable for. And you know, one of the things I love about Nolan is he tends to think like I do, is there are all these people who want to cherry pick patients and take the easiest to treat. And Nolan has taken the hardest people to treat. And had, you know, we didn't mention the exact outcomes within Nolan's studies, but he's looking at outcomes that are dramatically better than we've seen in standard TMS trials.
Yeah, I saw 80 to 90% types of response rates. But do we know if all three elements are necessary? Or is there still more work to be done there?
One of the problems with all of TMS research is we really don't know what the ideal protocol is.
Right.
I once went to a lecture that my buddy Juan Comperdon did at one of these meetings, where he's talking about how do we make TMS better. And he, you know, because we don't really know how many treatments you need. We don't really know how many pulses you need to do during a particular session. A lot of these parameters we don't know. And he outlined all the different studies that we needed to do. And we're looking at billions of dollars worth of research to improve our outcomes another 10 or 15%. So I'm not sure what's going to be the most important part of the secret sauce that Nolan has developed. There has certainly been some argument about whether the targeting is essential. And there have been some arguments as to, you know, exactly how many sessions. The point is we have to start from, okay, Nolan got these results using these parameters. Okay, where do we go from here? And the problem has been that there really is not tremendously good funding to take this to the next level, to see what whether we can improve the treatment outcomes, or are we exceeding what we need to do in terms of how much stimulation we're providing.
Yeah, and that's sad, because these are incredibly important clinical questions at the level of patient care.
Yeah, they are, because depression's heterogeneous, and so it's likely in the end not all depression runs through the same neural pathways, and so we're going to have to think about that too. Has there been additional work longitudinally yet to know? So you get better with SAINT, then what, right? And that's the old ECT question that's haunted us now for the history of ECT. Do we have findings yet on, you know, intermittent treatments or going on antidepressants or something?
Yeah, I can comment on some of the points that were made by Scott and Linda, and then that as well, Stephen. So we have a couple of really interesting neuroimaging papers that seem to discern, you know, SAINT responsive individuals pre-treatment, you know, and so that's the tail end. So to be determined. We agree with you in the sense that not everyone's going to be the same. You know, there's clearly a signal in the people that seem to be SAINT responsive on our kind of predictive imaging work. I've been fortunate enough, there isn't enough funding generally to cover, you know, this sort of work. And I totally agree with what Linda and Scott said. I will say that NIMH has been supportive of this work. And we actually, to your question around dosing, we have a study right now ongoing, recruiting participants where we're scanning people every single day to try to capture effects and, you know, and clinical scores every day, so we could try to get a sense of this, which I think is great. It's a very involved study, as you can imagine. You know, you're spot on about the observation around ECT. As you know, about if you look at the Harold Sackheim work, you know, 25% of people will relapse within the first week after an acute ECT course with treatment-resistant depression, if not provided with maintenance. You know, most people will relapse at the 6-month mark without maintenance. And so it seems to be probably a kind of a phenomenon of depression, more from my perspective than actually a device or, you know, treatment specific thing, that there are just people with different relapse trajectories. That seems to be true with SAINT as well. If you look at our single subject data, there are a couple of people who've already kind of relapsed by the 1-month mark. I can't give you details, but what I can tell you as a general statement is it appears to be totally dosing responsive. If you give people enough, they will maintain it out as long as you go. I mean, at least the year mark. So it's really a dosing phenomenon, which is great. In the kind of acutely responsive individuals, you can kind of keep it going. And that's that's encouraging. I think it tells us that it really is, if that system is responsive, that kind of target is the right target for that individual, then it's really a dosing phenomenon, just like with ECT, which I think is great. And so lots of work to do in that domain in particular. And hopefully over the next couple of years, we'll have better answers for that.
And Nolan brings up a really good point, because I mean, I tell everybody we have no permanent cure for this kind of depression. And it's highly variable when people will relapse again after they have a successful course of TMS. One of the things I know Nolan's group is working on is trying to, jump in there and intervene. And this is something that I've been interested in my own research is, how to do that maintenance. And it's probably a very different schedule for different people. Some people, I don't know, have better plasticity, they stay better longer, and others, as he said, will have a relapse trajectory where they're getting sick shortly after that final treatment session. So this is Nolan's work is another opportunity for us to tackle this really important question about how to keep people better with TMS after we get them better originally.
Yeah, and it's not unique to these, right? I mean, we have that experience with most psychiatric treatments, right? When we get early responses and then have problems over time. So good. The kind of final thing we can talk about, and then we'll wind it up, is when the people watching this, when can we expect that this will become available enough that it will be practically part of our treatment armamentarium? I mean, I know that's not true now. Do we have any sense of that or prediction?
Definitely, yeah. So some of my students are now in a company called Magnus Medical. Most of the first authors on that last paper, and they're working with industry folks trying to figure out a way to get this out. So from what I understand, over the next year there'll be a kind of Saint specific sort of device that's really optimized to deliver this approach. And the game plan is to get into these high acuity settings where long length of stay is tricky, right? Where having folks stay suicidal in the hospital for a long period of time is really tough on the patient, tough on the the healthcare system, and trying to find ways like this to kind of optimize it. And so I think that's what the next year will look like. And then hopefully the ball continues rolling for more areas to be affected.
Right. And from a safety profile, so far things look pretty good.
Yep. So to date, knock on wood, we've never had a seizure from Saint, and so there's never been anyone receiving this approach, in my domain, as far as I know, the company's domain, and so on, where there's been a seizure, which is the one risk that you think about with conventional TMS, although it's really rare, and then kind of 1 in 30,000 sort of session time frame. The real side effect that people talk about is headache, right? So Tylenol responsive headache. But I would say, as a generality, I'd love to hear what Scott and Linda think about this. But my view of TMS, just generally, conventional TMS, Saint, whatever it is that it's one of the safest devices in medicine. If you really look at the safety profile of TMS, there are very few things in all of medicine that have a safer safety profile than TMS. And I think that that's really great. I mean, patients tell me they either, with conventional TMS, right? You have talked to thousands of people at this point, and they'll either say, doc, I feel back to my old self, or I feel, halfway there, or whatever, or I don't feel any different. But you never hear anybody say, I feel better, but I feel weird, or I feel better, but I don't feel myself. That's not really something I've heard anybody say with Saint, with conventional TMS, whatever it is, right? Which is really, really nice, I think, to be able to tell patients.
So any other comments, Linda or Scott, you'd like to add as we wind this up? It's been a very interesting conversation. I know these are brief, but anything else you'd like to add?
I just want to underscore what Nolan is saying. Part of the magic of neurostimulation, other than ECT, most of the side effect profile from ECT is the fact that you've had a seizure and you're getting anesthetic agents. Is with TMS or with VNS, is there really is not, we're not doing any changes, systemic type changes, and largely the effect of medications and the side effect of medications is, hitting serotonergic neurons that aren't in the brain. And so we're able to target our treatment. And in fact, people tolerate TMS incredibly well. And as somebody who specialized my whole career in treatment-resistant mood disorders, TMS is about the most benign thing I do.
Yeah, if we could get it a little bit more convenient so more people could access it, because Steve, there's so many people who could benefit that either don't know about it or aren't referred or don't access it. So Nolan's work and other work that people are doing to make it more convenient, more accessible are really important.
Yeah, no, I think all of you have been pioneers in this, and I appreciate the work you're doing. And it just strikes me once again, the stigma around our conditions. Nolan, you kind of hinted at this, but didn't say it. If another branch of medicine had a very safe technology that would dramatically improve outcomes, or even just improve some people, right? It would move along faster. And so part of the things we can all do together is continue to advocate for better care for our patients. And we're hopeful that as this continues to roll out and move TMS forward into new and innovative approaches, that's exactly what will happen. So good. Well, thank you all. Very interesting. I've learned a lot. I hope that the people who tune into this or read the article find this helpful. The sort of take home is it's still evolving. We're still learning stuff. We're still trying to get it available. But there's a lot of promise in these neuromodulatory techniques that we hope continue to advance how we benefit the lives of people with mental illness. So thank you.
Thanks for having us.
Thank you.